Good morning, and welcome to the webinar on standards for identifying evidence-based practices in reproductive health, hosted by WHO Implementing Best Practices, UNFPA, USAID, and also the IBP HIP Task Team. I am Karen Hardy, the director of the Evidence Project, and I'm really pleased to be moderating this webinar, which is one in a series that this group is organizing around maximizing family planning investments through evidence-based programming. This topic is clearly of interest. At last count, there were over 500 people registered for this webinar in nearly 60 countries. So there's really increasing recognition of the value of making decisions that are informed through research-based evidence. And our speaker and discussants are really well placed to address these questions. Why is there a need to clarify the standards of evidence used to inform decisions? Different decisions require different evidence, and thus are the standards of evidence that we use flexible enough to answer the range of questions regarding the decisions that need to be made for programming. There are decisions on impact and effectiveness. Does this work? Does it work better than what I'm already doing? There are decisions on implementation and scale up. There are process questions and incremental improvements and efficiency questions. And what about the interaction between evidence and other factors that go into decision making? Our three panelists today have extensive experience both generating evidence and also in its use for decision making. We participated together in a session on standards of evidence at the Health Systems Research Conference in Cape Town last year and are really pleased to be together again for this webinar. Our speakers are Dr. Ian Askew, Director of Reproductive Health Services and Research at the Population Council, and Ian comes to us from Nairobi, and he'll focus on the evidence related to decisions regarding impact and effectiveness. And our second speaker, Dr. Nam Tran, is the manager of the Implementation Research Platform at the Alliance for Health Policy and Systems Research, based at WHO. And Dr. Tran will address evidence needs for decisions on implementation and scale-up. And finally, Dr. Patrick Obwaje, Director of the Family Health Division of the Ghana Health Service, will focus on the role of research-based evidence and other factors in reproductive health decision-making. And I've asked our three panelists to keep their remarks to about 10 minutes each so that we'll have time for questions. And our audience, if you could please type questions in the question box as the speakers are speaking, and we'll address them after the presentations. So with that, I would like to turn the floor over to Dr. Askew. Ian, could you... We're turning the screen over to you. That takes just a second.
Ian, you're in control now.
Okay, thank you very much, Karen. So good afternoon or good morning, everybody. As Karen indicated, we've organized today's session around three aspects of standards of evidence. And I'm going to spend 10 minutes, and just 10 minutes, talking about standards of evidence as they relate to decisions around what approach should we be using in terms of reaching a particular population or delivering certain services. And my colleague Nam Tran will focus more on decisions around how do we best implement an approach once it's been determined. In this session, I'm going to look at three broad issues. First of all, issues of design and how they're associated with the types of evidence. In other words, which type of research designs are best for generating which types of evidence for which types of decisions. Secondly, it should be self-apparent that generally evidence from several studies rather than from one study is preferable. And so one of the challenges that those involved in using evidence to inform decision-making face is trying to summarize evidence from a body of evidence from multiple studies. So I'll touch on some of the issues that we face in doing that. And then thirdly, once you've summarized the body of evidence, it then has to be used for making decisions. And so I'll conclude with some thoughts around that. So this is intended to be a very brief overview of these issues, and we hope to stimulate discussions and further considerations amongst the audience. So turning to the first point around study designs. For most people, an RCT, a randomized controlled trial, is considered to be the gold standard or the best form of design for generating evidence around whether something works or not, whether it reaches its intended audience or what effect it has. And this type of design comes very much from a medical heritage. It's a very well-used design in a lot of medical research. And this is because it's very good at controlling for alternative possibilities. It helps to minimize bias, and it's a very good design for eliminating any chance occurrences that may be happening. And so from a theoretical perspective, randomized controlled trials are very good for determining whether a particular intervention has a particular impact on a particular population. It's a rigorous design, and it generates quantifiable evidence. And so for many reasons, it's a very good design for generating evidence. Beyond the theoretical reasons and design issues, it's also, and I apologize for the new English word here, its understandability is important. Decision makers, particularly those with a medical training, and a lot of people in the Ministry of Health come from this background, understand RCTs and appreciate what it means when they hear that evidence has been generated from this. Evidence from RCTs is highly publishable, and so for academic researchers it's a good way to go. And it's very usable as an evidence base for systematic reviews. Most systematic reviews focus on using data from RCTs. So in those senses, it's a very good design. However, when we're trying to apply this type of design for generating evidence to inform decisions around service delivery, and family planning programming, there are challenges because quite often it's difficult, it's quite often unfeasible to use this type of design, and it can pose ethical challenges. So what we find quite often in this field is the use of evidence from non-randomized, quite often called quasi-experimental designs, that are often used to answer similar sorts of questions. I won't go into detail about various types of quasi-experimental designs, and 3 of them are provided in the box in the slide that you see at the moment there. A control before and after design, an interrupted time series, and a prospective cohort designs. And we can discuss these further later on if need be. But I'm raising these because it's important to bear in mind that some of these, and particularly the control before and after, do produce very rigorous designs, and they use matching as a principle for enabling comparisons between your intervention and comparison groups. They can do multi-stage sampling, they can generate quantifiable evidence. So for many people, evidence from these types of designs are pretty equivalent to the designs for the evidence generated from RCTs. A second important point is that these types of designs often allow program managers some influence into where the study takes place, which populations are involved. And this we quite often find is important when it's impossible to randomly allocate different districts or different populations, different communities, different clinics to either to an intervention or a control. And so by identifying the experimental or the intervention sites initially and then matching them with comparison sites allows program managers to have some control over where an intervention is implemented. And thirdly, this design also allows a lot about learning about how an intervention is implemented in a real life setting. And this is something which Nan Tran will talk a lot more about in his presentation, but it's an important characteristic of this type of design that enables them to generate important evidence. So that third bullet about learning about implementation in a real life setting means that you're able to generate evidence that has good external validity. That is, it's useful for scaling up interventions, which is a critical aspect of the type of research which we're talking about in this seminar. So that's some issues around the first design, the first issue that I wanted to cover, and hopefully we can revisit some of these in the Q&A. For the second issue, I wanted to move on to talking about how do you bring together and how do you interpret a number of studies that may use these types of designs, either RCTs or quasi-experimental designs. And generally, what we try to do is try to summarize a body of evidence using what's called a global health evidence framework. And I'll go on now in the next couple of slides to discuss what we mean by an evidence framework. A useful definition is given here by Luoto et al., who defined it as a framework which uses multiple domains to arrive at a summary judgment of the evidence for community or population health interventions or programs. And these frameworks move the judgments that you can make from a body of evidence away from just basically sort of an expert opinion. An expert sits down, reads 10 studies, and then pronounces on the quality of the evidence, to a more formal process where they take into account various criteria, domains, and so on. And so if we take this as a more systematic or more rigorous way of making decisions around a body of evidence, some of the characteristics for using an evidence framework are that they should be guided by a theory of change. They need to be methodical and transparent procedures so that those reviewing the evidence know which type of evidence has been included, which has been excluded. The evidence is often rated across multiple domains. Some of these I've put up there, for example, the study designs used, the quantity of evidence available, the relevance of the evidence across the different studies, how consistent the results are across studies, the different contexts in which different studies are undertaken. And some well-known examples of such frameworks include the GRADE framework that's used a lot by WHO, the United States Community Preventive Services Task Force framework, and DFID has its own framework as well. So there are a lot of frameworks out there that have different types of multiple domains and are used in different ways to try to summarize the bodies of evidence. And then furthermore, each evidence framework often has a different way of coming to a summary judgment about what is the evidence telling us and what recommendations can we make from this body of evidence. And for that, again, it depends on the evidence framework. Most of them try to be fairly rigorous and formal in the way in which decisions are made by setting up expert working groups that will review the findings and will then determine the strength of the recommendations that can be made. Quite commonly, excuse me, these take the form of a systematic review, and I've put this in quotation marks because systematic reviews have a very formal process to them and have traditionally focused on looking at bodies of evidence around effectiveness rather than implementation. And as I say, Nan will address this in more detail in his session. But we need to bear in mind that when someone talks about a systematic review, they are talking about a review of a body of evidence that has followed a particular set of procedures and a particular protocol. And so quite often it's important to think about what is the body of evidence that we're looking at and what type of evidence is appropriate for which type of decision. And sometimes systematic reviews are not always the most appropriate. It may be more useful to have a let's call it a rigorous review rather than a systematic review. In this slide I've just put up now, the types of bodies of evidence that are most relevant when done through systematic reviews are those that are looking at the efficacy of a service intervention in meeting the health needs of an individual couple or couple. And these are the types of evidence that are used primarily to set up service delivery guidelines, to inform the the medical eligibility criteria, for example, And these types of bodies of evidence are important because they seek to maximize the internal validity, how true are the findings around the effectiveness of a specific intervention on particular outcomes. However, when we're looking at issues around programming and developing service delivery systems, quite often we're interested in the effectiveness of how do we deliver interventions through programmatic approaches. And this type of bodies of evidence are more focused on developing more broad-based programming guidance rather than specifics of does a very particular type of intervention have a particular type of outcome. And so these bodies of evidence are more focused on questions of feasibility and how do you implement different interventions, different programming strategies in different settings. And so the type of evidence that you put together and summarize is less concerned with internal validity and more concerned with feasibility and implementation. And then broadly speaking, a third body of evidence is more focused on sustainability and if something is effective in delivering, how well can it be sustained and how well can it be delivered at a system or national level. And many of the interventions that we're seeing in recent years that look at system strengthening and at scale up are focusing on generating evidence for this type of evidence for this type of decision. And in this type of decision, the body of evidence really needs to focus on the context in which interventions are being implemented. What do we understand about how interventions are implemented in different contexts, and particularly around the costs that are associated with this. So the purpose of this slide was to highlight the various different bodies of evidence that could be generated, and these in turn will require different types of study designs to come up with the different levels or standards of evidence needed. I've tried to compress a lot of ideas into a short period of time, and for those of you that are interested in learning more about or reading more about this, then I'd point you towards the report of a consultation which was held with a number of researchers, decision makers from programs and from donors that explored these issues in greater detail. But just to conclude, I wanted to put out 3 suggestions that we could discuss together as going forward. First of all, at the moment there is still a tendency towards looking towards randomized evidence as the preliminary type of evidence, the best type of evidence that's available. And this is skewing the way in which study designs are set up and are funded and how they're documented and communicated. And so first, I would encourage this community to accept and support the generation of evidence that is plausible from non-randomized yet rigorous research designs of the type that I described earlier. That use match designs, that use multivariate analyses, that rigorously document how implementation processes are carried out, and have much clearer descriptions around intervention study design. Secondly, I'd encourage us to consider deciding on a uniform standard of evidence. For example, agreeing on a particular evidence framework and rating system amongst the many that exist, agreeing on a process for determining and defining different strengths of recommendations, and determining what standards are appropriate for which type of decision. And then finally, it's critically important to be able to communicate the findings from these evidence reviews effectively and clearly. I think we still have a long way to go to realize that ultimately evidence informs choices, and so it's important to provide a range of options in making those choices rather than trying to look for a traditional silver bullet, one only approach is the only way to go. And so evidence informed choice should be where we're looking at, and we should be communicating our findings from these types of reviews with this in mind. And always we should be describing the standard of evidence used in developing the studies, the different studies, in how we compiled the body of evidence and how we rated and interpreted the findings and how we drew the recommendations from these. So in summary, those are the points I wanted to start us off with. And I'm happy to hand over to Nan to move the discussion forward with a focus more on implementation issues. And we can revisit some of these during the question and answer session. So thank you very much. And Nan, I think it's over to you now.
Ian, thank you so much. And yes, now you'll be getting the screen. Right.
Well, thanks very much, Ian, for that great start to the webinar. I'd like to, as Ian said, move a little bit to talk more about the type of knowledge that is useful when we're thinking specifically about the implementation of policies and practices and implementation of effective interventions that have been proven using some of these methodologies that Ian has already described. What I'd like to do is perhaps, and I want to say up front that this is the perspective that we at the Alliance for Health Policy and Systems Research have acquired over the last few years as a result of the work that we have been doing in terms of supporting implementation research in various different settings. And what I'd like to do is perhaps just remind us of some of the challenges related to implementation, and then talk a little bit about some of the approaches to implementation and why implementation failures often occur, and then share with you some of our current thinking about how best to integrate knowledge generation and use in the context of the implementation of effective interventions or policies. I think most of us are very familiar with this graph. This is the cascade, this is the PMTCT cascade, which shows at various different stages that there is a lot of dropout. So despite the fact that we actually have very effective interventions to prevent mother-to-child transmission of HIV, you see here that we lose women at various stages. And this, in fact, another way of looking, in fact, at this is not as dropout, but as a failure in our ability to effectively deliver these programs and services to the women who need them in order to prevent transmission of HIV/AIDS to children. So that's not new. And I think that, again, we also recognize that many of the health issues that we as a global community are trying to address are, in fact, preventable. Whether we're talking about maternal deaths, whether we're talking about under 5 deaths, many of these things are actually not issues that are caused by the lack of interventions. We actually have interventions for many of these things. What we are struggling with is how to effectively implement them and to ensure that we don't have the dropout, that we don't have failures in implementation that we're still seeing, and that remains a challenge for us. And I think this issue is becoming increasingly recognized, obviously, within the global community, global health community, but even outside the global health community, it's become an issue that has drawn a lot of attention. In 2010, the Economist Intelligence Unit published a report called Enabling Efficient Policy Implementation, whereby they looked at implementation from a variety of perspectives. They interviewed and surveyed organizations both in the public and private sector to try to get a better sense of some of the challenges that these types of institutions were experiencing in relation to the implementation of policies. And again, although it focuses largely on policy implementation, I mean, policies doesn't necessarily mean national health policy. Policies that they refer to were things that pertained to program policies in terms of looking at policies around certain services. So these are the types of things that we would think about as interventions. So what they found was not surprising. I mean, to most of us, I think they found that poor implementation was widespread. And of course, as we would expect, that poor implementation is damaging to a large majority of companies and organizations. They also found that 30% of the organizations admitted right out that they were at best only occasionally effective at implementing policy change, and that a half of them even said that they were only somewhat effective. So that means that half of these organizations surveyed, public and private institutions, said that they struggled with implementation and that they were at best somewhat effective, which is, I think, quite compelling. And I think that it speaks to the challenge that many of us are experiencing, and I think it's important to recognize that this is not an isolated problem, that certain certain health centers or certain health districts or certain countries are experiencing, but this is something that is quite universal. And I think that's why it's so important for us to have some thinking about how do we best support these processes. Again, they found that among government respondents, almost 90% of them suffered some negative impact, and about half of them actually admitted that poor implementation or implementation failure hindered their ability to deliver on their mandates and their missions. So this is serious stuff. And again, this is consistent with what was experienced in the private sector. So it's not, again, either a public sector issue or a some country issue. It's actually a universal issue that's cross-cutting across domains and sectors. I won't go into detail about the reasons that were cited for implementation failure, and I think you'll have access to these slides and you can see for yourselves. And there are a range of issues. Some of them relate to poor planning, some of them relate to lack of engagement of the appropriate stakeholders, and others relate to lack of use of technology and incentives, for example. In my opinion, implementation failure is quite simple. I mean, one of the main things that I think implementation is about is about change, and I think that we often don't look at implementation in that way. But ultimately, when we're talking about implementation of a policy, we're talking about implementing changes. And simply put, change is very hard for most of us. Speaking for myself, I know that it's hard to change. And I think that we don't always conceive or conceptualize implementation in that way. But if we start to see implementation as change, I think that some of the assumptions that we have made about implementation and the types of knowledge and the types of research that is needed to support this will change as well. So I've started to list some of the assumptions that we've often encountered when we think about implementation and why it's so hard. And I've put in red change. So again, I ask that if you look at this and you start to replace policy making and implementation with the word change, I ask you to consider whether or not those assumptions would still hold. So I think there's an assumption that we often make that policy making and implementation of these policies are highly rational processes, and that the idea that evidence-based practice or evidence-based decisions result somehow in rational choices. And again, ask yourself, if you replace policy making and implementation with the word change, whether you would still agree with that statement. Another assumption that we often make is that the implementation failure results from this thing that has been put forward over the last decade or so, that there's a no-do gap, and that the reason why implementation failure occurs, or the reason why we don't put into place an effective intervention that has been proven, is because decision makers or implementers simply lack the knowledge. And I'm reminded, as I look at this statement again, if you put the word change in there, about what I learned in my early courses in public health when we talked about behavior change. And I think that two simple examples. We all know that there are a whole host of reasons why people don't use condoms. Why, despite the fact that if you ask most people who aren't consistently using condoms either to prevent pregnancies or to prevent the risk of sexually transmitted infections, they'll tell you that it's not because they don't understand the risks, and yet they still engage in those practices. And similarly, I mean, if we look at smoking and why people continue to smoke, I think it becomes clear that the overriding or the overarching reason why people don't change their behaviors is not from a no-do gap. Yet within this field, we continue to talk about this no-do gap, or this gap between research to practice, and the implicit implication there is that what we need to do as a field is to translate that evidence from the science, because it's somehow not understandable, and to make it understandable for those people that are responsible for making decisions, because the reason why they're not doing so is because they don't have the knowledge. And I think we have to move away from that assumption. And I think, as Ian has said, I think there's an assumption that there are single solutions, as Ian has said, this idea that we want to actually find a single bullet, a magic bullet, to fix a lot of these complex challenges. And again, if what we're trying to do is bring about change, is a single solution what we really need? Is it realistic for us to expect that there is a single solution, and is it even desirable? So I think we've started to look at this in a slightly different way. And first, we're starting to think about, what is the knowledge that's required to inform implementation, to inform health system strengthening processes, because ultimately that's what implementation is about. It's about strengthening the system to deliver services. It's strengthening the system to integrate interventions. And again, I think we can look at health systems in a number of ways. On the one hand, we can see that health systems are machine-like organizations. On the other hand, health systems are comprised of complex social, political phenomena, and that they are made through human action and human interaction. And the way that we understand these things, cannot be solely from a purely quantitative or positivist paradigm, and that on the other hand, we need to incorporate other types of research paradigms in order to answer some of these questions. And so Ian has talked a lot about the types of research that are needed and study designs and models that are needed to inform and the quality of evidence and standards of evidence. And I would like to just add to that by saying, as we enter into the discussions about implementation, that it's not just quantitative sciences that are important, that increasingly we are looking more and more to the social sciences, to anthropology, to be able to understand and respond to complex issues that arise as a result of human interactions, community engagement, community preferences, cultural values, and all of those things that come into play when we talk about implementation. I think the other thing that we're starting to think about is that if you accept my thesis that implementation is really about change, then I think we have to look at the process of implementation as a process and not an event. So often we think about arriving at evidence or conclusions that can inform implementation, and the expectation is that, yes, we've discovered that this strategy can work to deliver this service, and that is the answer that you need to do, and it's a one-time change. And I think that I'm reminding us by, putting up the stages of change model, just to remind us that, implementation is a process. And included in that process is relapse. That, again, health systems are comprised of people, and people, and what we're really getting at is behavior change. And behavior change is not a one-time, and even if it happens once, it may not always stay that way, and those changes may not always be maintained. And so we have to think about this as a process of change, and we have to think about then the type of knowledge that is needed in that way. So the question that we ask now is not really what is the solution that's needed to bring about this change, but rather thinking about what is the process that is required to help bring about this change and to help maintain this change. And I think we recognize, obviously, that increasingly it's not just a matter of one single study, that there are a lot of contextual factors. There's tacit knowledge that comes into play when we're thinking about how changes occur, and in fact that it's an interaction between these things that actually informs decision making both at the institutional and individual level. And we also recognize that this is an iterative process. And this is where we actually see implementation research. Implementation research helps facilitate this process. Implementation research really helps to understand context, understand tacit knowledge, understand preferences. And again, it's about bringing in those pieces of knowledge in addition to the intervention that helps us to bring about change and maintain those changes. Really what we're talking about now more and more at the Alliance is thinking about this as rather than a linear process whereby we're translating evidence and putting into practice, we're thinking about it as a transformative process. And we're also conceiving and conceptualizing this not as a linear process, but increasingly as a cycle, as a cycle of learning. I've borrowed this slide actually from the Institutes of Medicine from their 2012 report, and I'm happy to provide that reference should anybody be interested, that talks about the continuous healthcare, the continuous learning healthcare organization. And they, again, sort of arrive at this similar conclusion whereby, this artificial separation of science, evidence, and care is useful at a conceptual level, but may be practically less useful because it creates these barriers and it creates this idea that somehow there's a knowledge gap and that what we need to do is fill that gap. And I think what the focus now is thinking about how do you strengthen implementation processes by integrating knowledge generation activities so that those processes are effectively learning processes. I'd like to just end my talk with some reflections. One, I think that one of the things that we've realized as we're thinking about change is that it cannot be imposed upon people. We can't tell people to change, and it's simply not a matter of saying one needs to do this. That's what the policy is. Implementing the policy and making the policy work is a different story. And that is a process that comes about through learning. And I think more and more we're thinking about the ways that these policies are framed, both at the institutional level and at the program level, perhaps as goals that we work towards rather than a directive or a change that is necessarily imposed. Secondly, I think we're also thinking more about how to institutionalize iterative learning processes within systems and institutions. And one of the ways that we're trying to do this is to actually embed research within program processes, so that we're no longer funding research, on one side and then funding programs on the other side. What we're actually encouraging is that implementation research should actually be funded as a part of program processes. And it doesn't necessarily mean that we fund researchers. We are actually trying to engage implementers in this process, and we've actually had a number of initiatives whereby we are actually supporting directly program managers and other implementers as the principal investigators of some of these initiatives, so that they're actually addressing issues that are relevant to them, and they're also addressing it in the context of program implementation and not as an isolated academic exercise. And I think, of course, we've also recognized the need to incorporate alternative forms of knowledge, looking at issues that respond to questions about why, how, and how do we bring about things like tacit knowledge and contextual factors into consideration as we're trying to strengthen implementation. Second set of reflections, I think we're also recognizing that it's not possible to design a perfect implementation scenario. That is, what we've often tried to do is get evidence and say this strategy works for implementation. So what we need to do is to replicate this strategy, and this is my bias, and it'll come out. But I think a lot of our colleagues and grantees that we've worked with say we really want to test this strategy using a cluster RCT because it's going to generate generalizable knowledge, and what we want to do is to then replicate that strategy elsewhere. And I think that it's never going to be perfect. You'll never arrive at a perfect implementation scenario. What you can do, however, is to design good implementation processes that have iterative learning built in that will then facilitate implementation. And the science of implementation, in my opinion, is exactly that. It's thinking about how do we develop effective and learning processes that support implementation. My last slide here, I just wanted to say that, implementation research, and this again leads to what Ian has already said in his previous presentation, provides knowledge and insights to inform choices. It does not provide single solutions or answers to complex challenges and questions. And it is not an exact science. It does not guarantee that the choices and solutions will work perfectly. This is why we see it as an iterative process whereby there is learning, and then there's some learnings that are important come from negative findings, and we often overlook that because we focus so much on getting those positive findings and positive results. And finally, the last point I just wanted to say, and again, this comes from our experience working in countries with a lot of our projects and counterparts, is that research does not equal decision making. While we certainly believe in the value and the importance of research, and certainly implementation research, we also recognize that decision making is a complex art, it is a complex science, and these two things are not the same. We hope that implementation research that is embedded within these processes can help inform the choices and the decision making and the understanding that's necessary for decisions to be made, but we recognize that it's not the same. So that was just a very brief overview of some of our current thinking, and I'm happy to answer any questions later on during the discussions. Thank you very much.
Thank you, Nan. Thanks so much. We are going to try to turn the screen over to Ghana. We're having some technical difficulties, however, so we're not sure if we will get the comments from Dr. a budget. If not, we'll come right back to our questions, but we're just going to try to see if Ghana is on the line. Patrick, you're on if big pardon?
I'm mute. Okay, it's fine. Yeah, we are here. Can you hear me?
Yay, wow. Great. Welcome.
Yeah.
Yeah, please.
Thank you very much.
Absolutely.
Yeah, I think we had two beautiful presentations, and both presentations are quite instructive. And for NAND implementation, as presented, it's instructive, especially when it talks about the interplay between the tacit knowledge and the contextual factors, and then how the health system influences outcomes. Our experience here as program and as policymaker is that health system challenges are usually overlooked, and they are the ones responsible for some of the failures. And then we also ignore some of the multi-sectoral roles, especially when it comes to the infrastructural ministries, such as roads, etc., in reproductive health, local government, and the health decides to go on its own. It creates the problems that we tend to have, and we result in failure. Sometimes lack of long-term planning, and even where they exist, is usually not appropriately updated. It also has been shown to be part of the reason why we fail. And with Ian, it's extremely, I mean, this rigorous research we cannot overlook. It's very important. But what we always want to do is to ensure that involving policymakers from the inception of the study through implementation to dissemination is crucial to influencing decision making and use of the evidence that the research predicts. As we said earlier, evidence has always been part, as policymakers, part of the consideration that influence any reproductive health initiative that we do here. It may be before the design or the implementation. Sometimes during the implementation, there's nothing before, but during the implementation, we get the evidence. Or sometimes it's before and after, or before and during the implementation, especially when the initial evidence is not convincing enough, and we have to do something. And this research, it can come from rigorous research, as Ian explained, but sometimes a lot of evidence, tacit evidence or tacit knowledge, based on health experts' experience. And I must say here that we have a lot of good experts in our country who have not been taught how to document. And so they have a lot of things that is undocumented, even though it's evidence that is undocumented, and they influence a lot of the decisions that are made as far as policy changes and influence are concerned. But the challenge that we normally have with evidence is that how much weight does it play? Because there are several factors that are other plays in terms of how we involve decision in the implementation of factors. What is the weight? There are many variables that we look at. The evidence, as we've been trying to get across, is will it work? Will it address the challenge we have to convince ourselves as policymakers it will? What is the credibility of the source of evidence? Is it from partners? Is it from WHO? Is it from a local NGO? Is it from programs in country or outside? Is it an NGO or a CSO that's providing evidence? As a policymaker, you have to consider all that very, very critically. Is it affordable? Is the intervention affordable? Is it scalable? That's a very, very critical part of whatever we do. And is there any country experience everywhere, whether evidence or no, but has any country done it? Has any part of our zones done it? Is there anything that has been done before? And most importantly, one of the most important ones, will it be acceptable politically? Is there a political will? Is it socially acceptable, and is it culturally acceptable? These are all the things you will need to do. And sometimes when the problem is big, if the magnitude of the problem is huge, with or without evidence, intervention will start. And hopefully we'll learn as we go on. I can give an example of our tax shifting when we try to allow community and this is the lowest cadre of our health staff to provide contraceptive implants. Despite two researchers' assessment that really proved the evidence that it works, it became quite difficult to convince people because of fear, other policymakers about the fear of failure, enabling legal environment. Is there policy support? How would the community accept that? All those things influence it. But however, when evidence became overwhelming and the need also became clear, especially when the demand for implants outstripped our capacity to deliver, it became a lot easier to make a change. And then that's something we're doing. So in a nutshell, this is some of the key factors that influence policy. Evidence is extremely important. Sometimes we don't take it serious, but I think along the way we have to go back to it during implementation or somehow, and then we tend to get back to this evidence to prove that it will work, especially when we need to scale up these interventions across the entire country. So that would be my brief comment that I would like to make. I'm very grateful for the insightful presentations by Ian and Nan.
Great, thank you so much. Thank you so much. I think now we will open up the question panel, and we'll ask the panelists. We will thank you, those of you in the audience who've written questions. We will we'll ask the questions and direct them to the relevant panelist. So Luigi, if you could open up the question box. The first question is directed to Ian, and it asks to explain more about what the theory of change, what a theory of change for research would look like. And maybe if you have any examples of where theories of change have been used that you could maybe direct to this questioner. Luigi, are all the panelists unmuted? Ian's yeah, unmute. Great. Ian,
okay.
You're on.
Thank you. Yes, you're
Sorry.
unmuted now. Yeah, that's okay. I've used the term theory of change partly because I'm hoping that people are becoming increasingly familiar with it, but it is a term that others, it describes a variety of other concepts, but essentially it's an expected relationship that you're looking at, and in other words, a hypothesis that you want to test, and a reasonable expectation of what will happen. So in looking at generating an evidence framework, then generally the idea is to start off with some expectation of what is it that you can reliably expect the intervention that you're looking at. Why would you expect it to have the outcome that you're expecting it to have? Now this might sound very obvious. For example, if your intervention is to use community health workers to provide a particular form of contraception when they haven't been using it before, you may just go ahead and do the study without providing an explanation about why you think that is a good thing and why you think it's going to have an effect. So putting forward a theory of change forces the researcher and the people using the research to explicitly state what they expect to happen. And this is always in terms of a change. As you heard from Nan, the focus of this is on evidence to inform change. And so why would you expect a particular change to happen with a particular intervention? And so it's very important to describe and explain that clearly at the beginning, so that the research can then be set up to determine and to test whether that is actually what happens in real life when you test this out.
Great. Ian, thank you. I would like to just keep you on the line for one more minute, and there's a question about You talked a lot about RCTs, and there's a question about the methodology of using a difference in difference approach in non-randomized trials. And I think we're hearing more and more about difference in difference. And for those of us who aren't statisticians, it's like, oh my goodness, what is that? So maybe if you either explain it quickly or point us in the direction of something we might read to get a better comfort level among implementers of what that is.
Okay. I'm also, like you, Karen, not a statistician, so
Okay. Sorry to put you on the spot.
a statistician. But essentially, the idea is that in a design where you're comparing both, an intervention with a comparison group, and you're comparing them over time, then a difference in difference analysis is when you make both comparisons, and you use statistical techniques to make those comparisons simultaneously. I hope that's a correct explanation, but it's my interpretation of it. And if there's a statistician on the call, it would be good to hear from you as well.
Thank you. Thanks so much. Nat, I would like to maybe turn it over to you now with another question of the and by the way, panel. I mean, to the panelists, there were lots of thanks for your presentations. But one was talking about the tensions that arise in having to ensure robust learning during implementation. And that is the idea that research often takes a relatively long time compared to the time that implementers have to make decisions. So does that mean that there's a need to slow down and have far more reflective program design and processes? Or does it mean that research needs to be quicker and less robust? So, Nat, I don't know if you want to start, and Ian, you may have some thoughts on that also.
Sure, thanks, Karen, and that is not at all a loaded question. I think that the answer to that is, I think there's a wide range of study designs and research methods that allow for more rapid generation of results and knowledge that may be useful for implementation. I think that a lot of times when people talk about the length of time that's required for research, they talk about the quantitative studies that are actually based on trials, and it takes a long time because you need to have the right power, and you have to have the right sample size and all that stuff. You have to have the time in which to measure the impact. But I think that once you step away from, and I want to clarify that I think that most design is perfectly appropriate in some studies, so that a lot of the questions that are asked or that are required during implementation may not always be answered by those types of designs. And I think that's what I'm speaking to, is that I think we want to encourage a broader perspective of implementation research, so that on the one hand, you may want to test a particular implementation strategy using a quantitative design, whether it be an experimental design or otherwise. But on the other hand, you may want to employ qualitative methods that may not take the same length of time. And I think that we certainly are not arguing for any compromises to the rigor of the research, and that we want to encourage that's not necessarily needed. I think is what I'm saying, is that I think there is a balance that can be struck between having rigor, appropriate research questions, and also I think ensuring that implementation processes do include these. So I think that the point that perhaps do we need to modify implementation processes? To some extent, yes. I think we should ensure that implementation processes are structured in a way that we do build in opportunities for learning. But I don't think that it's a question of toning down, if you will, the rigor of research, or having less an expectation that somehow implementation research should be less rigorous. I think that there are a range of study designs that enable for more rapid turnarounds that don't always require the same length of time.
Of qualitative research, and I think you're absolutely right. Just qualitative research can be equally robust. Let me ask you another question, and that is, how broadly accepted do you think the relativist paradigm is across the field? Are donors trending this direction, or do you still see this as pushing back against a positivist norm?
I think that depending on who speaks, I think that increasingly, as Patrick, I think in his summary nicely stated, that I think there's a lot of questions that cannot be answered in the sort of positivist paradigm. And I think he alluded to some of them, issues around sustainability, feasibility, acceptance, all of those issues. I think you could certainly design a study using a quantitative approach to answer those types of questions, but I think that they're less useful. I think increasingly, certainly, we here at the Alliance and within our network of collaborators are slowly changing our perspective. So I think, yes, we are butting up against this sort of bias towards these quantitative approaches, but we are recognizing that there is increasing traction, and I think there is people, more and more people and organizations that are starting to recognize the value of other forms of evidence and the need to support this type of evidence research.
I'd like to direct a question to Patrick, and thank you very much for your comments on when evidence is used and maybe when evidence is sort of overtaken by other events in the policy process, or when decisions need to be made maybe without so much evidence. So one question is, at what point would one be confident, would one be able to confidently scale up an intervention without expecting much failure from one locality to another? So in Ghana, as you're thinking about scale up, with the evidence that you have, what's the thought about sort of variation among the different locations in the country when implementing an intervention in scale-up mode?
Yeah, thank you very much. Yeah, thank you very much. A lot of the time you look at, because of the variations in capacity at the various parts of the country, once you have your evidence, you have to vary it based on the capacity that exists in the various locations of the country, be it the leadership there, be it the infrastructure. So those are the things that you now look at to see how, even though you have the evidence, sometimes the scalability will vary slightly from place to place, looking at all these factors. But the most important is that when you have had that and you have a proper policy change, then the fear of failure is out, and so you are able to push further and modify until you are able to scale up in a way that we all want, and ensuring that you are informing local leadership in whatever scale-up practices we are doing now.
Okay, thank you so much.
We're currently trying to do another task shifting of maternal health for community health nurses to doing, but we had a lot of inputs from the regions telling us exactly how it should go. Despite the initial evidence that we have, their own inputs are also shaping the way we scale it up. So it is how we do the balancing to balance all that, especially the social acceptability and then leadership and the political will within those localities that we want to scale up.
Okay, thank you. And I would like to just address one more question to you, and that is, Nan talked a lot about the need, that sort of the change process that is needed for implementation. And the question was, could the presenter speak more on approaches that are useful to take that lens, the lens of a change? And outcome mapping is one that comes to mind, where the focus is on understanding change processes. And the question is, are there others? So Patrick, in the environment in which you work, can you think of change processes that would help in translating evidence into into decision making, or get the role of evidence to take more space in the decision making process?
I think that it's how the evidence is gathered is extremely important, and how the various policymakers and program managers, especially in reproductive health, have been conscientized throughout the process. And also expanding the network. We have one of our key challenges that we have so many development partners with different positions on issues, and so even though they may not be part of the country ownership, their influence is so important that it is important that they get their buy-in to ensure that we are able to scale up such intervention. So donor buy-in or partner buy-in or local NGOs who are there are crucial, and the local politicians are very crucial areas that we really have to take a look at as we scale up, especially when some of the challenges of the scaling up have to do with funding. And so that aspect is extremely important, that we take that aspect of the change process too.
Excellent, thank you. The final question I'm going to read isn't really, well, it's a question. I'm not sure that any of the panelists have an answer, but I want to leave us with this thought, and that is, how can we better advocate for resources to evaluate our innovative implementation strategies? Service delivery organizations mostly get funding to innovate and implement and monitor. Resources for rigorous evaluations are scarce or non-existent. So maybe we could just open up the lines for all the presenters. If any of the presenters would like to make a comment about this comment, you'd be more than welcome to. We just have about a minute left, so if you just keep your comments brief. So are the panelists unmuted? Yeah. If anybody, would anybody like to comment on this comment that we need, that service delivery organizations need more money for research to evaluate their innovative implementation strategies?
Well, Tian here. I can understand the frustration being, part of the research community, and I think it gets back to realistically being able to provide evidence to donors who are on the one hand requiring increasing levels of detail about how well the programs they fund are being implemented, how effective they are being, but they're often not providing the resources to the service delivery organizations to be able to demonstrate that level of impact. And I think it behooves those that are funding interventions to realistically fund evaluations that would enable them to provide the data that is being required by donors to be able to justify their funding.
Thanks. Any other panelists?
Patrick, I think sometimes it's also about the multiplicity of the challenges in our environment that we have. So sometimes the prioritization, especially the government agencies, wanting to say, should we spend money answering this question, or should we go ahead and address another problem? And I think it's all like Ian said, it's more of a risk-off challenge that influence. But I think everybody believes that they need to know what is working. But the myriad of challenges that are faced that we need to, it's all about prioritization.
Right. Okay, thank you, and thank you for indulging us going over by just a few minutes on this really interesting webinar. I would like to take the opportunity to thank our panelists for their presentations and comments, and for all of you for joining this webinar. The webinar is the slides, and I think the recording will be available on the HIP website. So you can go there soon to get copies of the slides and the webinar. So thanks everybody for joining.
Thank you. All right. Yes.
Quick before you hear the comments.
I know.